My name is Leila Harrison. I'm the Senior Associate Dean for Admissions and Student Affairs at the Washington State University Elson S. Floyd College of Medicine. And I want to have my colleague here introduce herself as she takes a sip of water real quick. But Dr. Bender, I want to have her introduce herself.
Ayanchu. Okay, Ayanchu, good afternoon, everyone. Ke sutimi Naomi Bender. My name is Naomi Bender, and it's really nice to meet everyone.
So today we're really focusing on deconstructing barriers for aspiring Native American health professionals. And while I'm at a medical school, Naomi is at our campus, which represents nursing and pharmacy programs as well. So really, I think the information we share can absolutely be applicable to other settings outside of medical school. So want to make sure that's stated outright. And so I want to just dive right in and talk about how those of us that are in admissions hold a lot of power for either upholding barriers or deconstructing them. And so the way that we design our processes, the way that we lead admissions committees, interviewers, and so on to make decisions, if you're involved in these processes, you hold that power. And it's really important to recognize that and to see what agency you have to help deconstruct those barriers that exist. And so you've already heard this morning, and if you're familiar with holistic review, we know that at least in medical school, historically, traditionally, and still at some medical schools, there still is this weighted difference with metrics, that the metrics, and in particular for medical school, MCAT scores, undergraduate GPAs, these metrics do carry weight in who gets into medical school. And sometimes influencer for these things are rankings, U.S. News and World Report, and other types of rankings, assumed privilege with higher metrics averages, pressure. There might be leadership pressure at the provost level, the president level of the institution to have these higher metrics, interest from state legislators and others, right? So there can be those pressures that exist to have higher metrics for your matriculating classes. But in holistic review, the idea is to balance these because metrics don't really tell you a whole lot about mission alignment and your goals of your program. So your applicants' experiences and attributes are still very important. And I also want to clarify that holistic review and the balancing of these doesn't mean that metrics are unimportant. There is a lot of data that indicate that metrics that have value in terms of later predictability for performance, but it's using them responsibly, right? And so issues that come from this are unnecessarily weighting metrics, those MCAT GPA in the medical school context, having those imbalanced with experiences and attributes, having an unclear mission, you heard that earlier already, bias in selection, you heard that from one of the presentations earlier, that unstructured processes, and it's supported in research literature, can introduce more bias, so we want to mitigate bias. Lack of support. If your higher leadership do not support a holistic, intentional process, you're going to struggle as an admissions person making these decisions. So lack of support can be an issue. And not using your outcomes to inform how your process works and what you use to make decisions. Whoops. So what are some of the solutions? Utilizing your local outcome data to inform thresholds for metrics. How do you define success through the academic progression in your program? And how can you use those outcome data to inform back to your admissions metrics and how you look at them, right? How often are we looking at our own data to tell us what we need to be looking at in admissions? So that could be a solution. Making sure you're translating your mission, your vision, and your goals into tangible, aligned criteria. So ask yourself, is everybody in your process that's making decisions, your admissions committee members, your interviewers, does everyone really understand what that mission is? Do they know what it is that you're looking for? Yearly training, yearly bias training, having a diverse committee that's making decisions, training about your criteria. Does everybody understand what the criteria is and how it's defined? Having a structured process is absolutely a solution and supported by the literature. Transparency and inclusion. The power of sharing how you do things and your mission with not only the applicant pool, but the public is important. The more transparent we can be, the more likely that those mission-aligned candidates are going to choose you back. They're going to initiate that process by applying to your programs. But you have to be clear about what that is. And the inclusion piece of it, I start off every interview day with our applicants to medical school telling them, you belong here. We did not choose you by accident. Intentionally, we went through your application and feel like there are things there that align with us and you belong in this space. And we hear it all the time in our feedback on interview day as they say, those words were powerful and made me feel like I was included. Evaluating your outcomes from pool to pool each cycle. So we have these pools in admissions, right? We have the applicant pool or the application pool. Then we have, if you have secondary processes, you have the secondary pool, you have the interview pool, you have the accepted pool, and then the pool that eventually matriculates. And as it goes through that funnel, it narrows. There's fewer and fewer people as part of those pools. Are you looking at those pool yields from year to year and within each year? And then I love that this is right after the community college talk. Are you recruiting at community colleges? Are you making an intentional effort to do that work as well? So when we talk more about this pool, so this is kind of the funnel that we know in admissions. In the medical school space, we have 2 national application services. Then you have a secondary application, whether the applicants actually submitted the secondary, the pool that you interview, the pool that you accepted, but then the pool that finally matriculates. And so when you look at these pool yields, who are you losing as this funnel narrows? Are you losing the mission-aligned people you actually want to recruit? And if that's the case, are you screening them out, or are they not choosing you back? And if it's one of those, or whichever ones it is, why is that the case? Is your process the barrier? Are you not being communicative enough? Are you not being inclusive enough so that they're not staying with you? Because I think we have to remember, it isn't just us that have the power in the decision making. Our applicants also have the power in deciding back to choose us. So I'll talk a little bit about our program. Our mission is pretty clear. We're a young medical school, so I think that helps. We have, from the very beginning, thoughtfully included these processes. So our mission is to solve problems in challenging healthcare environments. We're in Washington State, and we specify that to mean rural and underserved communities in Washington. We want to help Washingtonians live longer, better. So we're really clear about this, not only in how we talk to our applicants, but it's on our website. But the way that we translate that in our process is also really clear. And so this group of populations on the left here are what we call our mission-aligned groups or populations. We're wanting to recruit and enroll rural people that come from rural backgrounds, those that come from low socioeconomic backgrounds, first-generation college graduates, military, underrepresented in medicine, and we are actually in a state like California where we're prohibited by law from considering race and ethnicity in admissions, so it's blinded to us. And I want to clarify this one. People might think, well, how is that mission aligned? Military, help me understand that. Well, prior service members bring a unique understanding and skill set to solving challenging healthcare problems. In the state of Washington, we have a lot of veterans that live in our state, many of whom also live in rural areas. And prior service members have a unique understanding about the barriers that veterans face. And so they bring a unique, important understanding to helping us solve those problems. And in our process, the way that we evaluate metrics, again, they're not unimportant. They still matter, and there's still enough predictive data that tell us about later performance. But we look at them at the secondary stage. So we've established data-informed threshold combinations of GPA and MCAT based on national data. We're too young yet to have our own consistent long-term outcome data, so we're relying on national data in the meantime, which is robust. And so our applicants have to meet one of these to receive our secondary application, along with residency pieces and so on, right? And they're transparent on our website. These are transparent. We don't hide these. But once an applicant meets one of these and submits the secondary, we completely blind these metrics. There's no human in our process who ever sees an MCAT and GPA. So what are we focused on? We're focused on attributes and experiences that align with our mission. And it is powerful, y'all, to have conversations at the admissions committee, and we're not talking about MCAT and GPA, that we don't ever see them. It allows us to really be thoughtful about what we're doing. So this is just kind of evidence of that data, and I want to make sure I'm staying on time here. So this shows these mission-aligned groups, and here I specifically pulled out American Indian and Alaska Native. And you see that from the complete stage, those that submitted the secondary, all the way as the pool narrows to matriculated, each of these populations that are mission-aligned are increasing in percentage as the pool narrows. It tells me that the process is working. right? If I was seeing this go the other way, then there would be something is going on. Here's another one, and this is the current year, which is not yet concluded. When you break down the underrepresented in medicine groups, again, as the pool narrows from complete to accepted, you see that those populations are increasing within those pools. Looked at another way, you see of the groups that were complete, so they completed a secondary, 70% of American Indian Alaska Natives we interviewed. 77% of our Black applicants, 70% Hispanic. And we haven't even begun making offers off our wait list, but this is where we stand currently of those that we interviewed that have been accepted. So this is what's important. Look at your data. What is your data telling you? And then just real quick, it's so important that a holistic review doesn't just stop with enrolling a diverse mission-aligned class. You have to support the students you enroll. Do you have resources to be able to do that well? And that's a lot where Dr. Bender is going to come behind me and share a lot of that information. But some examples of how we have holistic student affairs is we do really thoughtful, detailed onboarding starting like in April, May timeframe before the August matriculation, really beginning to help them feel inclusive, better understanding what they need to do, making no assumptions that all of our applicants understand what the space is. You heard earlier, I didn't know that you couldn't not match to residency. We want to make sure our applicants, we don't take for granted that they understand what this new space might be when we're enrolling a lot of first-gen candidates. Financial education. We're one of only 3 medical schools that has a full-time director who does financial education. He does individual meetings from our accepted applicants all the way through our graduates who are in residency, helps them build out payment plans, budgets, and really what we want to do here is we want to help our students make career decisions not based off of debt, and help them understand how to manage their debt, develop a 10-year payoff plan, and he meets with them and whomever in their family they want to be included in those meetings, and he meets with them repeatedly throughout their 4 years and into residency. And that is powerful. You've got people coming into medicine who often choose not to come into medicine because of the debt and because of they already have existing debt. So when you can, just destigmatize that, then you can help them develop skills. We found it to be really, really important. But that's another, if we're enrolling a lot of low SES students, we need to be able to support them. So that's one way we do that. Robust career advising from year 1 all the way through year 4. And when we get into year 4, our students all form a match team that follows them from the beginning of year 4 all the way through match week. That is a team that they choose that helps them with strategic application choices, with interview feedback, with rank order list decisions, and then supporting them through SOAP if necessary. But it's a team that they choose, and it's been really powerful as well. We also have a faculty coaching model. Every one of our students is assigned a faculty coach in the pre-clerkship years and then in the clerkship years. And then Dr. Bender is going to talk to you a lot more about the Native American Health Sciences support as well. And so finally, we are lucky to be partnered with OHSU School of Medicine, UC Davis School of Medicine, in a program that we call RISE. And these programs in particular are pathway programs meant to support American Indian and Alaska Native students. This is a summer program for people who are thinking about applying between 1 to 3 years in the future to medical school. And then this post-bac program, all 3 of our medical schools offer conditional acceptance to American Indian Alaska Native students that go through a 10-month post-bac program at OHSU. They don't have to pay for it, they get a stipend, and we offer that conditional acceptance if they meet our requirements. Excuse me. This is 2 of our awesome medical students. Lexie is our first-year medical student with us. But powerful. In this kind of partnership, getting outside of each medical school, competing and wanting to do their own thing is how can we do it together is way, way more powerful, I believe. I feel like I'm like an auctioneer up here. We talked about that because it's not a lot of time and I could spend hours talking about this. But I'm going to pass it over to Dr. Bender and she's going to talk more about the services they provide.
And I'll try to be a auctioneer as well. Is it just, which one is that? This one? Okay. And then when we get to the student section, can you hit the voicing? Because I'm not going to be able to, I don't think, from here. Okay, so be patient with me as I try to fly through this information as well. Thanks so much for being here. I'm Naomi Bender. I'm Indigenous Quechua, and I am the Director of Native American Health Sciences for Washington State University. We have 5 campuses and a global campus, and It's my job to serve all Native students who identify as American Indian, Alaska Native, Indigenous from the United States and across the world, and support them in their health and allied health sciences. It's not a small feat. We have the College of Medicine, which is a fantastic partner, the College of Nursing and College of Pharmacy on our Spokane campus, and that's where me and our team and our center is housed. But we serve Native students on our Vancouver campus, Tri-Cities, Everett, and other campuses as well. And there are several people in this room that I work with, and we work with your programs at your universities, including OHSU, UC Davis, UW's in the room. So I just really appreciate those that are here and who partner with us. I'm just going to run across a couple little whys. I think many of us know the whys. We heard them earlier. But when it comes to American Indian Alaska Natives, they make up less than 1% of all health and allied health professionals in the United States. And in this last cycle, through the AAMC in the 2021-2022 cycle, over 62,000 applicants overall nationally. Of those, 689 were AIAN applicants and 226 matriculated. So although there was an increase in the number of applicants, there was a decrease in the number of matriculants this last year, even with growing programs across the United States, which means we have work to do. We still have work to do. Because I serve all health and allied health, I do have to mention really quick, nursing has stayed around the same in terms of BSN, number of AIAN applicants, but we saw a decrease in the number of matriculants this year, an increase in DNP and PhD programs across the country. And then when it comes to colleges of pharmacy, there were over 13,000 applicants across the US, and 48 were AIAN. And of those, 40 matriculated, and 10% of those are at our College of Pharmacy. And as we see the increases of numbers of those students in our colleges, it attributes to the fact that each of our colleges have such fantastic admissions policies and leaders, period. So I have to say that. I came to Washington State University in the fall of 2018. This is a slide from when I applied in one of a 10-hour day of interviews. Those are always fun. I know you all love those. And I pulled this out. The day I came to interview, I had looked up as much information as I could. I'm not familiar with Washington. I'm a Minnesota girl, born and raised in northern Minnesota, served at the University of North Dakota InMed program for many years, and then also the Center of Excellence to a HRSA grant there for allied health sciences for many years before I came out here. And I had served 26 tribes in the Midwest. So coming out to the Pacific Coast was like, holy moly. Way more tribes, completely different histories as I would expect. And when I came here, I said, these are some areas any institution could potentially expand, but I'm not gonna really know till I explore more. So it's important to say that. I took a year and a half to spend time with the tribes in the Pacific Northwest to better understand their tribally ran or IHS-based facilities, their education needs, what kind of programs they had already for their students. I didn't want to reinvent any wheel or anything like that with our tribes. What were their needs? Quickly, our mission expanded. I've now been there for 3.5 years. The program director before me had been there for since 1995 and retired, and had 2 beautiful programs, a high school summer program for health occupations, and then a retention program that she served in terms of advising and supporting students in, at that time, pharmacy and nursing. And as she left, the College of Medicine started. And when I came, they had been around for about 1.5 years. And so, excuse me, happening you're talking so fast, you have dry mouth. So our number 1 goal is to expand the number of natives in the healthcare workforce. Secondly, this expansion is coming from all of my work with tribes, is to culturally embed education toward a more holistic and equitable patient response in Indian country. We need to do that. It's not taught in Western Ed. If it is, it's 1 or 2 patient cases, and now we've done our due diligence, right? And the third is to work more with tribal communities. Okay, I gotta get this right. Our work is supported and steered and advised by the Native American Health Science Tribal Advisory Board. And this is important because this is made up of a group of folks who are educators, healthcare folks, tribal leaders in their communities, and we meet 2 to 3 times a year. When I came in 2018, we were serving 130 Native pre-health students, mostly in our Pullman campus, and at the time had 35 Native students in the 3 colleges that I had mentioned, and College of Vet Med as well. Fast forward to the awesome work of Dr. Harrison and other folks in those other colleges that I mentioned, including Vet Med. We now have 56 students, and just last year we had 11 Native students graduate from those colleges, and it keeps increasing. So we now serve 57 or 56 Native students this year with 180. We saw a leap of 50 more Native pre-health students during the pandemic. We aim and work nationally with IHS, the affiliated tribes of the Northwest Indians, the Northwest Portland Area Indian Health Board, the Portland Area Indian Health Service, tribally run clinics, the Association of American Indian Physicians, you name it, to help really create a more inclusive environment and work with everyone else, right? So we're all on the same page. And we commit to serving students with over 50 tribes in our area. And me and my small team serve on over 30 boards, which gets to be really busy. Since 2020, we went from two pathway programs to now 13 pathway programs for Native students. At least 3 of those are with the College of Medicine. We have one with pharmacy, one with nursing, one with vet med, and the list goes on. And we're just so thankful. I listed some of our partners up there like OHSU and UC Davis. We also work with UW Dentistry as well, and we just love working with them. In my time, we've also helped solidify a multi-program clinical agreement with the Portland Area Indian Health Service so that all of our students in those colleges may have the opportunity to rotate in IHS clinics. Those are important. I've also our office helps increase the number of clinical agreements in other tribal areas so it helps them. They want students in there too because they see high turnover rates as well. So those rotations are important. And I'm just going to move on here so I get everything out. In 2020, we built a new Native Center for Native American Health. It has 3 wings. I'm showing you the student wing. There are 3 PC labs that support students with HDMI TV and toggles for computers and support, scanning, printer, and testing support, so they can study there for their NCLEX exams or Step 1 exams, whatever they need. There's kitchenette and cultural areas. This spring, students are building their own healing gardens, raised healing gardens, so that they're able to plant some of their own traditional foods. And so we have all sorts of neat activities. Here you're seeing an elder's teaching them all how to paint and the history behind teepees. And so that was one of our really fun events. And this is a native medical student and what Center for Health does, our Center for Native Health does for her.
Hihaniwash Day. My name is Lexie Jones, and I'm a first-year medical student at Washington State University's Elson S. Floyd College of Medicine. I have known that I wanted to be a doctor since high school, and I knew that Native perspectives were very needed in medicine. Studying medicine can be very isolating, and it can separate us from our cultures. The Center for Native American Health is a place for Indigenous students on WSU's Spokane campus to gather, to learn together, to learn from our elders, to be mentored by Native physicians, and to be able to receive a lot of support while we're going through these very strenuous training programs. The center also does a great job of providing cultural activities for our non-Native colleagues and classmates to learn more about our cultures. And I am extremely grateful for the support that I've received through the center and through Native American Health Sciences.
I left 2 of our newsletters. They're in the middle of these 2 first tables. You can look through them and then pass them back. But in there's voices of all of the Native students that we worked with last summer in different programs. And Lexie happened to be one of the Y East program students with Dr. Harrison through the OHSU, UC Davis, and WSU PACT. And she matriculated this last year. So she's a first-year medical student. And it's okay. My goal was to try to see if we could hear a couple of these students. This is a nursing student who matriculated this last year, had no help in her first placement of undergrad school at a very expensive private school. She felt like an outsider, no Native support, and she ended up leaving with a pretty poor GPA and had to start all over again. And her GPA ended up being pretty high by the time she came back to try to matriculate, and had tried 3 times to get into College of Nursing and finally got in. But it took a lot of extra steps along her way, and she never gave up. And her mom, who's also a Native nurse, graduated from our school with a DNP, and she was bound and determined. But she said, the center you guys created is my home away from home. That's the only place I will go study on campus.
Hello, my name is Jasmine Tonasket. I am a member of the Colville tribe and a descendant of the Spokane tribe. I am also a J1 student here at the WSU College of Nursing. The reason I want to become a nurse is very embedded in my culture. I am inspired by other Native women who have led the way, like my mother, who graduated from WSU with a doctorate in nursing practice. I want to advocate and care for our people, and I want to make them feel comfortable in healthcare settings. Native Americans are underrepresented in the healthcare field, so having more Native nurses to provide care, educate our people, and inspire others is crucial. Being a part of the center at WSU with Naomi and Evan Lean has been such an important support to me since starting nursing school. I began my college journey at a school that didn't have support for Native students, but the warmth and familiarity that the center provides is like having a home on campus.
And then Jasmine is another Native medical student, year 2. She's been part of some of our summer programs. She works a lot in our clinical sim space as well, and just fantastic students.
Hi, my name is Jasmine Birch, and I'm a second-year medical student at the Elson S. Floyd College of Medicine. I am becoming a physician to help people when they are going through challenging times in their lives. The Native American Health Sciences Center has been a great source of support during my time in school thus far. It has been a place to come study, relax, or even share a meal with some amazing people. I always see friendly faces who check in on my studies and make sure they are doing all they can to support me. Over the summer, I have also had the opportunity to learn from various Indigenous healers at the center. Through their teachings, I developed my patient exam and communication skills with cultural humility at the forefront, which I plan on continuing to focus on when I am a physician. We need Native physicians in the workforce to work towards eliminating healthcare-perpetuated health disparities by working with surrounding Native communities, balancing Western and traditional frameworks in healing, and providing culturally centered patient care. Thank you.
The second wing in our center is a tribal community health initiative and partnership area. We saw a lot of need for that. During the pandemic, a lot of tribes were asking us to work with them and set them up with either epidemiologists or other scientists or researchers. So we're opening up a new wing for an affiliate group. We're also launching a brand new interprofessional Indigenous healing perspective certificate meant to help either current or future workforce folks who are working in Indian country to better understand how they're working with those patients in that particular community. And we're launching that this fall, and that's been supported and funded by a local health foundation, the Empire Health Foundation. Real quick, that's my Indigenous grandma and my mom up on the top left, and then me and my daughter. And during the pandemic, I had about $53,000 unused between me and Leila's funding. And I asked EHF, our funder, can I flip it into something outside of Pathways? And they're like what? And I said, I want to build the first Indigenous clinical sim space in the US. I am so tired of the only format of teaching inside any health education, Western medicine, and that's not to disparage Western medicine or medical schools, but we're only teaching from one perspective. And it has been too many times that my grandmother, and I put her up there for a reason, mistreated, misdiagnosed for many years. She passed away from ALS. It runs in my family, and to see the mistreatment in our family is horrible. And it happens to all of our it happens to so many Indigenous communities. And so I asked to turn it into this. I'll let you read there, but basically it's meant to help be culturally centered and to help balance Western medicine with what works with Western medicine with Indigenous perspectives of response to patient care. All of our doctors are allopathic, naturopathic, DO, DNPs, nurses, pharmacists, all Native. And they helped me design this space, decide what's being taught in this space. They're writing the standardized patient case scenarios for this space based on their own experiences in Indian country and in their own practices. And it helps to dismantle, right, racism, decolonize these types of spaces in the way we teach, and it indigenizes it. This is some of the group of folks that I get to work with in that space. These guys are awesome. I love working with them. We have an upcoming retreat where we all get together. There's over 60 of us getting together. And I'm at my last piece here, and basically why I put this up here is many folks across the nation who do work like Dr. Don Warren, Eric Brote, so many others, Leanna, so many people, Dr. Mary Owen, and really work towards putting this out. And if you haven't read it, I would really encourage you to, calling Reshaping the Journey, and how medical schools can begin looking at integrating pathways, but also curriculum in other areas that really mean better health outcomes for our tribal communities and our patients overall. Okay, man, that was fast. Real quick, we handed out 2 pieces of paper. If you didn't get them, they're in the back. One of them is about our center. So I'm going to give you that information. I'm going to let Leila talk to you about the other sheet. But this just gives some basic information about our center and what we provide students. And I just have to say, although we primarily serve Native and Indigenous students at the center, all students are welcome. We have students who are Black, African American, Asian, Latinx that say that this is the most culturally safe place to study on campus, and they work with their Indigenous peers, and they're coming in all the time, so it's pretty fantastic.
The other sheet was basically we wanted to like have you leave with something after today, and we can't possibly go through everything, but it's just questions to reflect on and take back to your institutions, is to talk about how can you begin to deconstruct the barriers. So those questions are meant to help you think through those through the deconstructing barriers through the different kind of topical areas. So, but we're happy to answer any questions that you might have. Yes, ma'am.
So this is not off data, but just speaking from my own personal experience with my peers. People who come from low-income communities and unstable families, they often have so much stress on their plate already to strive for higher things. And those Native students who are getting into medical school, they have such amazing emotional resilience to begin with. So I was wondering how, like, assessing for emotional resilience in admissions, how that plays a role over getting a good GPA or MCAT score.
Yeah, thank you so much. Such an important question. And resilience is absolutely one of the things that we're looking for. It's one of our attributes we look for, actually, in adaptability. And so we ask purposeful questions on our secondary application. For example, one of our essay prompts is about resilience. How have you built your resilience? And it's an opportunity for them, one, to tell their story so that we better understand what they've worked through. But it's a signal to them, too, that we care about this. And so that's one of the things. Those kinds of things are not always easy to assess, especially in an admissions process. But because we've made it one of our attributes that we are on our rubrics that we're assessing for, and then we have the dedicated essay regarding it, it does help us to put into perspective their kind of journey traveled, right? Their distance traveled. When we don't see MCAT and GPA, like I said, but we do see the running individual grades. So if we see blurbs, I don't think that's a word. If we see that they've maybe had a bad semester, then we can help put that into perspective by reading all of kind of their journey and their background and hardships and so on. So absolutely an important aspect for us in admissions.
Is there a way to make that more standardized?
Probably so. Yeah, it's a great question. I have no doubt that there is a validated instrument out there. I mean, I come from a psychology background. That's my educational pathway. And if I could do a battery of proven psychological assessments, I would love it. But I think it's a good point. And perhaps it is something that we could look at to see what the validity evidence of it is, maybe in professional school. So I love the question, and definitely I'll take that back.
Thank you. And the work you're doing is amazing.
Oh, thank you. Any other questions? Yes, sir.
So you're doing such an excellent job in encouraging and educating Native students, but the path to populate all of the rural areas that need any kind of primary care provider, and people that are educated or embedded into the Native culture in the rural areas, is there like a way that you can introduce some of this to non-Native providers so that those students that say are not Native but are intending to work in rural areas where there's a heavy Native population,
So
that they can co-educate or be embedded from the beginning so that they can learn? Because I'm currently in Northern California, and the Native culture there is very complicated. The generational trauma is something that somebody who was raised in California never understood, and I'm just blown away by all of the needs of a primary care provider to take care of that population. And there's not going to be enough Native providers in the next 10 years to fulfill that need.
there hasn't been for a really long time. Yes, Sarah? Can you repeat questions into the Okay. So he asked basically, is there room, curriculum, experiences, opportunities for non-Native medical students or health or allied health students and future providers to better understand and work in Native communities? And the answer is basically yes, yes, and yes. It is why the sim space exists, So please understand that although it's Native people teaching in that space, not only did they develop it or we develop it and we're teaching in it, but we're deciding how that sim space is taught and who it's taught by, right? Where normally Western medical education would say, we're going to teach it and we'll invite you in as a guest lecturer one time, right? And what we're doing is we're teaching all students on our campus. Our goal is to teach all Native and non-Native, because the reality is, you all know, if I say less than 1% of AIN folks are healthcare professionals in the US, that means who's left to serve our people? Over 90% are not, right? So we have to be able to educate them and help them in harm reductive strategies inside that space understand that when they're coming into a space and they're working with an elder or a family, and that elder may not be receptive right away, or there may be a number of other things, how to enter into a space of what we consider a sacred space of healing that's not necessarily taught that way in Western med. We're talking about dismantling implicit and explicit biases. What are some of the common microaggressions that happen that somebody who may be non-Native does off the cuff without realizing, thinking they have good intentions, but are harming the patient, right? And as we know that healthcare workers and providers perpetuate these health disparities, most commonly to the underserved, like our Native people, we have to find better ways in educating and inserting that education, embedding it so it's a fabric of education, not just some extra piece of equity that we're deciding comes after the fact. We do a disservice to our providers when we send them out into the world and we've only given them an option to take a DEI course that may have 2 patient cases that talk about Native patients. And then who are those taught by? Who wrote them? Who's breaking them down and helping folks understand the identity of the Native person within this patient context? Does anybody understand the historical context of that patient? What type of intergenerational trauma is affecting their health outcomes? What is their living situation? So there are many different pieces that are happening inside the center, but that sim space is meant to do that. We have one patient space. Bank of America just donated $250,000 for us to advance an entire new Indigenous wing. So we will now have an additional space for pediatric and maternal focus, a hospital room for end-of-life care, and a whole teaching area for teaching and healing modalities included. Yes.
Can you talk about how that's integrated into your curriculum?
Well, this is interesting because our office is central. I answer to the vice president. I'm not part of any college. So now we're at a point after meeting for 1.5 years with Indigenous healers where we're ready to really begin working with the colleges to integrate this inside all of their curriculums, because we had to get our stuff together. we were doing it during the pandemic. This group has met online every 6 to 8 weeks for 2 hours at night and made that space happen and started writing cases. And we're all meeting for the first time face-to-face on our campus the first weekend of April. So it's beautiful work, but it's going to be ongoing. And we're at the very humble beginnings of this work, but we will be including all 3 colleges and other students. And these rooms have Zoom capacity. So the reality is the people that's in this room, like all of our partners, if their students and their pathway students want to sit and watch an Indigenous clinical simulation happen, we can broadcast it across the US. And that's important because we can't keep it to ourselves. That's how I feel about this. We have to be able to share this work. Now, mind you, this is being taught by folks in the Pacific Northwest, and it's why I'm only showing you an example of what you can do inside an institution, but you should be working with your own local tribes, your own local Indigenous leaders, your own local Indigenous healers to do this work, because it's going to look different from region to region.
And I'll share too that for the College of Medicine, we're just about to graduate our 2nd class, so pretty young medical school still, but still a lot we can grow in and do, and I think with partnering with Dr. Bender in her office. But in our curriculum, we have a required 4th-year rotation where our students have to do a 4-week urban underserved or rural underserved. In those rural partnerships, some of them are on tribal land. We have over 250 clinical partners across our state, and some of those are with tribal partners, and we definitely have students. I think we're recruiting not just the American Indian Alaska Native students, but we're recruiting students like Dr. Bender was saying, who have done work within the communities and they are passionate about it. They're Latinx, they're other other race and ethnicity students, and so they care, and so they're already reaching out to Dr. Bender saying, I've been doing the work on the Lumi tribe and I want to, or the Lumi tribe, and I want to continue to do that here. So I think there's still a lot to grow in, but we're trying to be thoughtful of that. We have partners here in UW. I know Dr. Muski could absolutely speak about what they have done as well. So like there's other examples of thoughtful curriculum, of ways of doing this. And so, I think it's important that we all get this out there so that others have a way and a tangible ways that they can do it as well.
I'm just curious, because I'm a pediatrician and we run into child protective services, medical neglect. I do chronic disease. And so when a parent's not taking care of their child, I run into several circumstances, not just American Indian, we do this, various people have immigrated from Mexico and stuff like that. Do you guys have that in your curriculum? How do you work with people where it looks like medical neglect and you're trying to work with them to the best of their ability, best of your ability? You don't want to endanger the child because we're mandated reporters. But we run into these cultural barriers and it happens time and time again. And do you guys have anything in your curriculum that deals with that?
Well, I will say from the medical school, so is that I'm not in curriculum, so I can't speak to the individual things within the curriculum, so I can't answer that. I'm not sure. I don't even want to guess that that's there. But what about yours?
We're just starting our standard indigenous standardized case patient, case scenarios, and we do have a couple of pediatricians on board. One's a behavioralist, and so I envision those coming along as the year progresses, and that's the goal, is to build right in cases that we're seeing. But I can't say that we currently have a case that's reflective of what your question is.
I can guarantee you that we would love to hear them. Just because we keep hitting them, and it's like, where do you draw the line? Where is it, no medical neglect? Where is it? How do you get past those barriers? Because unfortunately, we're all mandated reporters.
And one thing to understand too, clinical simulation is meant to help, practice like your knowledge, your clinical knowledge in a same harm reductive space. And so you're never going to hit every case that you're going to go out and see in rotation or once you're out in residency. But our hope is to build cases that are meaningful based on individual healers' perspectives. And that's something you have to remember. What we're doing is not standardized, right? Because this is coming from healers who have been doing work for many, many years. And I think that that's the goal and understanding, is that healing is not just Western education. It comes in all forms and understandings, and to respect that on the patient's end is really important as well. And those cultural challenges and barriers that exist, we need to find better ways to teach how to walk into these spaces with not just humility, and get away from this understanding of being competent, because it's just not possible. But having somebody I look up to, Dr. Don Warren, calls as cultural proficiencies. Right? So we need to get to a space where we feel more proficient, like we have a basic knowledge, and being okay to say, I don't know, or I apologize when I've misstepped and I'm not right. And that's not common either in these spaces. So.
I think that was the word I was trying to come up with, is how do we teach that? Because obviously it's not taught when we're encountering these situations. So it's nice to have some examples of how others can deal with it.
Well, I think we want to make sure we're not late. We let our next speakers come up and get ready. But thank you all so much for being here. And we really love working with all of you this way.
We did leave our business cards on that back table, and there's some extra sheets to take if you're interested in sharing some with colleagues, but both of our business cards are on that back right table. I'm like dry mouth. How much can you spit out in like 15 minutes? I'm like,